Greetings from Team IMA. I am Dr. K.K. Agarwal. Welcome to our weekly show. And in this show, we discuss with one expert in great detail about one subject. This show is open to the medical doctors of IMA members as well as to the public, because some of the public issues we will also be discussing in this show. Every week, this show is brought to you in association with our digital partner, Librate, as well as our webcast partner, IMATV. And the public part of it is being supported by Heart Care Foundation of India, a NGO. This week, we are going to talk about radiation oncology. And the expert will be the head of radiation oncology at Medanta, the MedCity, Dr. Tejinder Kataria. Welcome to our show.
Namaskar. Thank you.
Now, what we are going to do, radiation oncology is a vast subject, but there are a lot of myths. Many of the doctors are also not aware. I know when I did my MBBS, radiation oncology was like at its infancy. We were not taught the way radiation oncology has gone this time. Whenever somebody asks Indian Medical Association, how do you define healthcare? We define healthcare as healthcare, a quality and safe healthcare which is available, affordable, accessible and accountable. So these 6 headings we will discuss regarding radiation oncology. That's why my first thing is, let's talk about the scope of radiation oncology. We know that if a person has cancer, he has option for radiation oncology, he has option for surgery, and then he has option for chemotherapy. Now, why they were now these 3 have now become a super specialties by themselves, a separate department by themselves. What was the need? Why couldn't have the surgeon himself could have done the chemotherapy, and he also could have had the department of radiation oncology?
Good afternoon, Dr. Agarwal, and good afternoon, listeners. Thank you for inviting me here. I think it's a very good question to ask as to what is the scope of radiation oncology. We always associate radiation oncology to treatment of cancer. But radiation not only treats cancer, of late for the last 20 years, we've also started taking into account and treating non-cancerous or benign lesions, especially intracranial tumors like small meningiomas, acoustic neuromas, and where the control rates with radiation are to the tune of 95% without any collateral damage. And also for recurrent brain tumors, low-grade gliomas, or spinal schwannomas, radiation has shown its potential and is being used worldwide. The answer to your second question as to why there was a need to separate out.
So the first message is very clear. Let's note it down. And the first message is that in benign tumor, radiation does not mean cancer. Well, that's a conception to the people that he has gone for radiotherapy, that means suffering from cancer. It may not be. Very large number of benign tumors, specifically in the brain, can be treated with radiation without being a cancer and without avoiding a surgery.
And the second question that you asked me was regarding why for cancer treatment, surgery, radiation and chemotherapy have now become separated. When we started off, about 500 years ago, when the surgical tools were very, very primitive, and surgeons were the people who were offering treatment to the patients, every treatment was accounted for by surgeons. But as we developed in the last 100 years, radiation has come to forefront, and the techniques have evolved to very specific pathways of treatment. And also the equipment and technology has advanced in such a way that it is not possible for super specialized surgeons or even a general surgeon to take care of radiation and its equipments and the delivery thereof. So radiation has evolved since 1930s as a super specialty of its own. And worldwide it's given as a degree separately from surgery or from medicine. And medical oncology came into its own in the last 30 or 40 years, but the first drugs were available to mankind after the Second World War.
So after an MBBS, now you can go into radiation oncology as a?
You can go as an MD. Radiation oncology. And also in our country we have DNB, Diplomate National Board, as super specialty.
Oncology, oncosurgery is a separate specialty?
Oncosurgery after general surgery is a super specialty.
Oncology?
medical oncology is a super specialty after doing MD medicine.
Hmm.
And radiation oncology is a super
And
specialty.
radiotherapy?
Radiotherapy is the MD radiotherapy, which is available after MBBS.
Hmm.
And the degree still in India is given as radiotherapy. There are a dialogue that's going on that it should be radiation oncology because you are not technicians.
So it
you
is
are
not after
doctors.
MD.
No, it's not after MD. It's an MD radiotherapy.
It's an MD radiotherapy.
And I was trained as an MD radiotherapy from PGI, but for the last 20 years we ascribe our subject as radiation oncology because we look after patients of cancer.
And
And
so
the-
therefore, all those medical students who might be listening to this program, if they want to take it as a career, what is the scope?
The scope is very large, especially because when we look at the Western data and also in India, cancer is becoming number 2 healthcare problem after heart disease.
Hmm.
And this is a disease which is a product of our aging and accumulation of insults because of the environment, because of the exposures, because of the
So
mutations.
because
that
of the
occur.
numbers, more and more centers are required.
More and more
therefore-
centers are required, more and more doctors.
As on today, how many
skilled people
radiation
are required.
oncologists will be there?
Approximately 1,500 radiation oncologists
Only?
are available in the country.
And what is the need?
And the need is approximately, we need approximately about maybe 8,000 or 10,000 medical radiation
So
oncologists.
that and so therefore there is a shortage of radiation oncologists in the country.
In the
You need
country,
it.
yes.
What is the investment?
The investment is that they need to do an MD radiotherapy and
investment.
investment approximately to set up a good center somewhere between 15 to 20 crore.
That may not be so easy.
That may not be very easy, so
Okay.
that's why radiation is normally a department which is attached to bigger hospitals. And there are standalone models like Rajiv Gandhi Cancer Institute where it's in a cancer institute, but at All India Institute of Medical Sciences, PGI, at Adyar Cancer Institute, Trivandrum Regional Cancer Center, and at Medanta, the super specialities and other general medicine and surgical departments
So
have to be
help
required.
us in drafting a letter to the Prime Minister
Yes,
that 450 or 500 crore rupees is nothing.
yes.
Okay, so the Prime Minister should be able to sanction 15 crore per state
I
and let
think,
them come out with one center of radiation oncology in every state.
I think we already have the National Cancer Program.
In that, in the
Yes,
all
and
radiation.
that the radiation oncology centers are now being allocated to the medical colleges. And that has already been afoot, and
So
every
it-
year
it-
maybe 2 to 5 centers
No, why every
are
year?
being given.
I'm talking about, I mean, do we have in every state a free radiation oncology department? I'm talking about a free. So
As of today, it's affiliated to the medical colleges,
even if it
but
is,
they need to be upgraded to the present state where the top of the line technology and skilled manpower is made available. So I think you're right in highlighting this felt
so
need
this is my
that we
fundamental
are
right
shortage.
under Article 14 and 21. I have a fundamental right to receive radiotherapy if I can't afford.
Yeah, that's right.
We'll come back to when it comes to the afford.
Yeah.
So we come back to, so this is what radiation oncology is. Is it available? Second question again is linked to that. Is it available pan-India to every section of the society?
It is available pan-India. We have about 350 radiation centers or radiation oncology delivery machines.
Hmm.
And some of them are concentrated at more than 2 or 3 in one center, but by and large 1 or 2 are available pan-India. Whether it is available to all sections in tier 1 and tier 2 cities, radiation oncology is available. People do not have to travel from far off distances as they had to do about 15 or 20 years ago. They can take it nearer to their home, but in tier 3 cities and in villages it is still not
So,
available.
but before that, because now we have 3 treatments. You have surgery and you say cure. You say no surgery with radio, or you say surgery with chemo or all 3 together. Which are the conditions where only radiotherapy is the cure?
I'll take it the other way around. Radiation forms cornerstone of treatment for cancer in about 70% of cancers.
Hmm.
And it is practiced in India and also in many of the developed nations to the tune of only 25 to 30%.
Hmm.
So except America and Australia and England, where radiation is given to almost 70% of patients, it's not available elsewhere. You know, it's available but not utilized to its complete potential. And radiation is curable for head and neck cancers, for cancer cervix alone, standalone, including the brachytherapy. We were talking of teletherapy or linear accelerators, but there is also a branch called brachytherapy.
Just define different terms.
Yeah, so brachytherapy is the term in which a source of radiation is kept close to the tumor or within the lumen of the tumor, like for an esophageal cancer, for an intraluminal therapy in the bronchus, or in the uterine cavity for a cervical cancer, or for the vaginal brachytherapy for a cancer of the endometrium. That is known as the brachytherapy. And also for cancer prostate, we place seeds within the prostate, radioactive seeds. In cancer of the breast and for soft tissue sarcomas, we place catheters within the tumor and or in the tumor bed, which saves the limbs. So brachytherapy can prevent an amputation in case of a arm or a limb, soft tissue sarcoma. Teletherapy means it's far away, like we are doing a telecast now, far away. So here the source is away from the patient, and you can treat a bigger area. You can treat right from a few millimeters to 135 centimeters, that is the whole body of the patient in one go with the teletherapy equipment. And the basic
conventional is tele, but brachy will be more like localized.
Yeah, it's localized, specialized, and you need to be skilled. You have to be trained to be able to deliver that.
So localized, specialized,
and inaccessible tumors.
Okay, go ahead. Let's go ahead with the availability.
And the availability, as I said, is pan-India, not in tier 3.
What about affordability?
Affordability in the public hospitals and in the teaching institutes, medical colleges, there is a very nominal cost which a patient has to pay, just about 500 or 700 rupees for the total course of treatment. In some centers, it's taken up to 1500 rupees. So within less than 2000, the complete course of 6 to 7 weeks of radiation is available for anyone who reaches that place and needs the radiation. And in the private sector, it's available between 70,000 to 1.5 to 2 lakhs.
Per?
The per treatment, the
There's
whole
no
course of
per
treatment.
sitting?
No, per sitting. No.
There's nothing like per sitting.
It's per course, you know, because the treatment is like a package. So you do the planning, you do a CT scan, do the simulation.
So is it covered in the CGHS?
It is covered in the CGHS and ECHS both.
CGHS, CHS,
and
then it is covered under Mediclaim.
It's covered under Mediclaim.
Is there any payout in Mediclaim? Mediclaim will cover fully.
Mediclaim will cover it fully, provided the person is insured.
Oh yes.
Otherwise, they'll pay 80 or 90%, or whatever is the insurance cover for that person.
No, I'm talking about if the person has
insurance, then it's fully covered.
then it is fully covered.
Yes.
So are there any restrictions? Are there differences of packages in various hospitals, or most of them they are?
They are basically, you know, the ECHS, CGHS are standard across India.
What is that?
And that's between 1.5 to 2 lakhs for various sites.
CGHS.
For CGHS and the ECHS both.
And for general public?
For general public also, for general public it's between 1.5 to 2 lakhs. Some palliative treatments, they start at 30 to 40,000, like you have to treat only 5 fractions or 10 fractions. And then it goes to radical 7 weeks of treatment, then it's up to 2 lakhs.
Okay. And these packages are independent of chemotherapy packages?
Yes.
So these are like radiotherapy packages with that. So when we talk about, so if a person is poor, he can't afford, then he has to go, are there, say example, say Medanta, do you cover BPL patients?
We cover the BPL patients, like we provide them a concession. We go to our CMT and there are certain laid down guidelines. So we give them a certain concession. And then also we have their travel, which is covered through the central government scheme for cancer patients, that their train travel is made free. So they can come and go every time for their treatment and for their follow-up. 75% of the concession on the train travel is made available for them. And then we have also tied up with some NGOs and some foundations who provide funds. And then we use those funds to treat these patients who are the BPL category.
So how many people might be dying from not getting radiotherapy? Not because they will not be able to afford that.
I think as of today, the percentage would be maybe less than 10 or 15%. But still that number is there. Because they are probably not able to reach in time to a place where they can receive the radiation that's required
So
for them.
that raises another question. Is it an emergency? Is there
It's
anything like
in
emergency?
radiation, yes, we have an emergency like a patient of cord compression with a lymphoma or a metastasis. Then it's an emergency. If the patient reaches us within 24 hours and we give radiation, then there is a complete recovery of the paraplegia or the stroke, or the cord compression. If they reach us within 48 hours, then 50% of them only would recover their function. So then it is an emergency. Then the second emergency we find is the patients with cancer cervix who come in with massive bleeding. So that's an emergency. They need to be given hemostatic radiation immediately. That way we are available 24 hours. And then also patients with superior vena cava syndrome, especially for carcinoma bronchus. So if they present with shortness of breath and they have florid superior vena cava syndrome, that's an emergency. We treat them and within 24 hours they are relieved of their respiratory
So that
distress.
gives a fundamental right. That means every state, it will be a crime on the part of the state not to provide essential life-saving equipment for these conditions.
I think I agree with that.
And we do get cord compression in India is common.
Yes.
Even-
Cancer-related cord compression.
Hmm?
Cancer-related cord compression.
I
Vertebral
mean, how common
deposits.
are these conditions? I mean, do you come across?
About 40% of our patients present with metastasis in the country, and 60% of our patients present in stage 3 and 4 cancers because of lack of awareness countrywide and lack of specialized services countrywide.
And
So
I'm talking about in emergency oncology, what will be the take-up, say, in a city or in a state per day? One case per day,
approximately 3 cases per week
3 per
in
week
a good center.
in a good center.
Yeah, where there is a high referral. So 3 to 4 cases per week. So approximately you could say about a dozen in a month.
So how many we want to be doing it in Vedanta?
We have a very good teamwork. So if the patient walks in into surgery or
No, I'm talking about emergency. I'm only
so
talking
in
about,
emergency we get about one a week.
and you end up into doing one emergency a
A
week,
week.
and that means if radiation oncology department was not there,
We could be doing that treatment.
we will be doing that to that. So when we come back to now again, when we come to accessible, available, accessible, and affordable. So is it 24/7 available?
It is available 24/7. So we have our machines which are running every day from 5 in the morning and till about 8 in the evening. And in case we also provide blood product irradiation for our transplant and for our medical oncology
How do you do that?
services. So the patients who are undergoing a transplant or who have neutropenic sepsis or who are in neutropenia when they undergo chemotherapy, they need blood products like platelets or red blood cells, and their lymphocytes needs to be irradiated so that there is no reaction to the patient who is receiving them. The donor may be harboring some antibodies, so they need to be knocked out. So then we irradiate the blood products. So that service we provide through the night also. So we receive the call at night and we have a
So the
technologist.
same blood which has been the same blood which has been collected, you
And
irradiate that.
that's after cross matching and grouping. Then that is sent to our department and we irradiate that blood to about 1400 centigrades, a single fraction, and then the patient is transfused this blood, and then they don't have the.
Where else it can be used radiation?
Like I discussed earlier, that the radiation can also be used for benign tumors.
How do you do that?
It's done in the same way as we do it for the other cancers, but the dose is lesser and the number
Or
of fractions is also
different
lesser.
from gamma knife and
Here we have a dedicated machine known as CyberKnife, which is a miniaturized linear accelerator of 24 inches mounted on an industrial robot, and it has 6 degrees of freedom, and it can create different pathways, more than 1400 pathways to reach the tumor. And the tumors have to be less than 7 centimeters in size. And
so with something like gamma radiation cyber knife, you're doing a surgery without opening the skull.
that's right. It's not only the skull. With gamma knife, you can only treat the cranial tumors. Whereas with the CyberKnife, you can deliver radiosurgery across the whole body, what we call as the stereotactic body radiotherapy or stereotactic arc body radiation. And here the number of treatments is varying from 1 to 5. So patients do not have to come for 6 to 7 weeks. And CyberKnife is more accessible for all body parts, including the brain. And here you can give more number of fractions. It's an OPD procedure. The patient doesn't have to undergo anesthesia. There is no scar. There is no cutting. Patient doesn't need to be admitted, and the tumors can be cured.
There is a therapy in homeopathy where what they do is they take the infected material and then they potentize it to 1 lakh dilution times, and they use it in the same patient orally. That is called as homeopathic nasode concept.
Okay.
I sometimes back was reading in US there is a trial going on in lung cancer. So they take the lung cancer tissue, and they then radiate it. Once you put a radiation into the lung cancer tissue, it will lose its infectivity, and then they do it, they repeatedly radiate it. I don't know how many times, but that's their patent. And then they converted it into an antigenic stimulation. They give it to the patient, and it is becoming like a lung cancer vaccine. Something of this somebody is doing it in India.
You know, we do not have any trial like this going on in India, but when we talk of the stereotactic body radiotherapy or stereotactic radiosurgery with the CyberKnife and with these high doses of radiation, radiation kills the tumor not only during mitosis, which is what the conventional radiation does, it also kills the tumors in S phase, G1 and G2 phase. And there is a complete shutdown of the vascular machinery at that time. And there is a intrastromal death also, or intermitotic death also. And the byproducts which are released, the cytokines which are released, they then go and are presented by the antigen presenting cells to the T cells. And then the antibodies are produced. And these antibodies then go and knock out or kill any circulating tumor cells in the body. So for patients who have metastatic disease, we call as oligometastatic, that is the number of metastases in the body is less than 5 and less than 5 centimeters in size. Those patients, if they are given stereotactic body radiation, then they are cured of that tumor with radiation alone. And that is because of the immune potential that is produced in the body, or the immunogenic response and the production of the antibodies, which kills the circulating
tumor cells.
tumor cells.
Hypothetical situation.
It is not a hypothetical.
No.
Okay, right.
Give
And
me
this
an
effect is known as
Give me a cancer. Name a cancer. With less than 5 centimeters and less than 5.
We are treating patients with breast cancer,
Okay,
lung cancer,
Suppose there is a lung cancer.
and prostate cancer. So the
Whatever. Let's take one. Let's take prostate cancer.
Right.
Less than 5 centimeters and less than 5 metastases.
Yes.
Now what you will do? You will do a stereotactic.
Body radiotherapy for each one of these metastases, which
All
are
5 of them.
yes.
That means you do a PET scan
You do a PSMA PET scan,
and then find out these are the 5 locations,
and then you treat them.
and you treat each one of them.
Each one of them to a certain dose, which is tuned decided for.
Then what will happen?
And then you follow this patient up.
So you are saying it, apart from these 5, all those minor ones which are not detectable,
Which are not detectable
will get
because-
killed.
will get killed.
Suppose instead of 5, if I do it only on 1, will it also affect the rest of?
There is some work which has been done as a phase 1 trial in which they have said, but not to a larger tumor size. If the tumor size is sub-centimeter, then they have said that in the clinic, in the laboratory, that these cells involute, or what is known as an abscopal effect occurs in this.
Suppose I take out a tumor. Suppose there is a prostate tumor, I've done the surgery, the tumor is in my hand. How can I irradiate it now?
No, if it has already been removed,
I'm putting a hypothetical question. Because
you know, you can irradiate, and you're thinking that this patient would need irradiation and then a
No.
vaccine formation, and then
suppose
going
I
back
take
to-
that cells, suppose I take tumor as a mass,
Right.
can it be irradiated?
Yes, it can be irradiated.
If I irradiate it repeatedly, once, twice, thrice, fourth, and then use it to the same patient, either subcutaneously or orally, and see the response.
Well, I think before we come to the patient, we have to have a proof of concept
No, no.
in the
What
laboratory
I'm trying to say,
to do that.
do it. Because this trial,
Hypothetically, I think it's feasible.
because
it's
this trial
possible.
is going on
For
with
lung
success.
cancer, yeah, for lung cancer, I believe that it's going on, and
Yes,
I understand
it's going on
Yes.
with lung cancer with success.
Yeah, so it's
Because no ethics are involved. You only require a permission because you are not using somebody else's.
body tissue. That's right.
You are not using somebody else's tissue. So no HIV, no hepatitis B, no hepatitis C. Two, it is not infective.
Right.
So you are using it orally.
Yes.
You are giving patients bone cancers have irradiated, asking to take orally.
Yes. I think the proof of the principle needs to be shown that yes, it is effective, and how much radiation to be given for which cancer. So that needs to be decided.
That needs to be.
Right.
That's what the.
So that's where the experiment is.
That's what the experiment is.
Yes.
That's what
Because
the
for a
experiment-
lymphoma, you need just around 4,000 centigrade of dose to cure them. For a lung cancer, you need almost 7,000
What is the?
centigrade.
Let me explain to you. The principle behind them is you convert matter into non-matter. So at what level of radiation
The matter becomes non-matter.
the matter becomes non-matter?
I think it's a
Simple,
scientifically it's a
It
very
is-
good
you are not
principle.
putting you are not putting cancer cells. You are giving the cancer cells converted into non-matter
Which is then the body recognizes it as non-self
as a non-self.
and then raises an immune response to it. I'm with you with
Is very clear about that
that.
because in homeopathic principles, if you dilute a particular drop 1:100, 200 is more than 6 times, it loses its matter.
Okay.
Similarly, if you take a solid, triturate it 1:6 C and 1:6 normal potency, it loses it becomes non-matter. And they use it 200. At 6 you become non-matter, but in non-matter also they go up to the 200. So those principles,
They are the scientific principles.
that's their science,
Yeah.
and it's not harming. It's not harming.
I think
I have seen septicemia patients, their own blood, converted it into in a sort. I've seen n number of cases. Patients on 1 drop of blood converted into diluted form by trituration, giving to the patient sublingually in alcohol, non-infective, and they septicemia improved.
I think that's a very good
So-
principle because then we can have a further cure, or the percentage of cure can be increased by a very simple way of treatment.
I never thought that this is possible in India. I was thinking, because when you said you are irradiating the blood products,
Yes.
if you are irradiating the blood products, I mean, I'm just trying to say, take septicemia, take patients of sepsis, and give them irradiated blood.
I think that would.
Just do a simple thing, that in every patient of septicemia,
We should give them irradiated blood.
give them irradiated blood
Mhm.
and see them in 30 cases.
I think
But
that's
if you get
something
positive
we can-
results,
Yes.
then put down
Credit is
acknowledgement, acknowledgement that Dr. K. Kirkar was suggested.
I think
There's
that's
nothing
a-
wrong.
No.
There's nothing wrong.
No.
There's nothing, cost is not a consideration in such a situation where you're ready to give ₹1,00,000 for gamma globulins without any effect. So cost is not a consideration. So if you pick up the next 30 cases of septicemia, even if they don't need blood, give them.
That can be discussed with the intensivist,
Okay.
and a study can be mounted.
No, I'm talking something different even.
Mhm.
I'm talking something different also. Take out the patient's own blood.
Mm.
Don't give outside blood.
Mm. Irradiate and then give it back.
Patient's blood, take out a unit of blood of the patient, irradiate it, give it. Okay? You don't find response, double irradiate it. Don't find response, 5 times irradiate it. See at what level the patient's response comes.
Very interesting. I think it's a study which needs to be planned and done.
I mean, there is nothing.
No,
it's
I
not. It only requires a independent ethics committee approval
That's right.
of the institution, and there is nothing. Unless we think differently, we will never be able to get a Nobel Prize in the country.
And if it
Otherwise,
comes-
if our research is research, not research, Because these are the things which
I think it's the out-of-box thinking which needs to be done.
that's what research is. Research is always out of box.
Yes.
Out of if you, otherwise it is a research. Somebody else's research did, you are only reintroducing the way. Think about it
Yes.
with that. So we do come forward for we do talk about quality and safety. So when it comes to quality, you said in between that machines are different, they need to be updated. That means there is a quality concern. Can it harm?
Like in all medical treatments, quality has to be preserved, and quality treatment needs to be delivered for a patient. So is true of radiation also. And here it's not only the machine or the equipment where the machine has to be maintained in a quality where the beam that is being delivered to a patient or the number of units that are being delivered to a patient are same every day. For 500 milligram of paracetamol you buy from the market or of the chemist, you know that it's going to deliver 500 milligram in the body and create such and such effect. And thousands of patients and thousands of pre-processes have been done before it comes to the chemist. So similarly in radiation, we have certain quality assurance tests which are done from the time when we have the mechanical installation of the machine. Then we do the calibration of the machine, we have the electrical calibration of the machine, and the electronics as well as the physics part of it. And then besides the treatment delivery machine,
so what are we used to see hairs goes away, radiation injury, radiation cystitis, radiation fibrosis, radiation-induced cancers. Are they still there or they're gone?
No, they are still there because radiation not only kills the cancer cells, since it's going to be delivered within the body. Cancer is not isolated from the body, and it's surrounded by the normal organs which are also growing. And here are one of the tissues which are growing. Similarly, skin is the tissue which is changing and regenerating every 6 weeks. So we take the effects of radiation to the tolerance of the normal tissues which are in the vicinity. So in case we are irradiating a skull or a brain tumor, then that part, the hair will go, but they'll come back in 3 months. It's not a permanent loss. Fibrosis is an end result of radiation. When the tissues have irradiated to a dose where either a lumen is being irradiated, like an esophagus or an intestine, so you have to always titrate the dose of radiation to the tolerance of the surrounding normal tissue. If you have a tumor in the retroperitoneum,
I will give you one more out-of-box situation. There are circadian rhythms, okay?
Yes.
And there are modern medicine circadian rhythms, and there are Ayurvedic circadian rhythms. The Ayurvedic circadian rhythms are 6 to 10, 10 to 2, 2 to 6, and then repeat. 6 to 10 in the morning is called inertia rhythm. They call them as kapha rhythm. 10 to 2 they say metabolism rhythm, and they call them as pitta rhythm. And 2 to 6 they call it as movement rhythm or activity rhythm. So according to them, the minimum activity of the cells in the body, normal cells, is 6 to 10 in the morning and 6 to 10 in the evening. Okay? So suppose you say in Vedanta we have a prime time that is 6 to 10 in the morning and 6 to 10 in the evening, and see the response versus other timings. Now what happens in 6 to 10 is, because the normal cells are sluggish, but the tumor cells will be active. But tumor cells don't behave the circadian rhythm. The first principle of a tumor cell is it has lost its circadian rhythmicity.
It's an autonomous cell.
It's an autonomous cell. So therefore 6 to 10 in the morning, the tumor cells will be killed, but the normal cells blink sluggish because their multiplication is the least. You will have the least chemotherapy, least side effects, whether chemotherapy or radiation therapy. Do it, think over, see 2 groups and find out, is it true?
Well, there are studies which have been done for especially head and neck cancers, where it has been shown that if the patients were treated before 12 in the morning, then their control rates and cure rates were better. So apparently it meets the criteria of the metabolic phase of the Ayurvedic system that you're talking
2 to 6 in the afternoon will be the best results.
Yeah, so 2 to 6, the patients who were irradiated, their results were poorer.
So you go further. Yeah, 12 se go back to 10.
In the morning.
6 to 10, you will get the best results.
Yes,
10 to 2, you will get the second best results, and 2 to 6, you will get the worst results.
I think that's.
If that happens, if that happens, for a hospital, for a corporate hospital, it can becomes like a TV slot, prime time, that if you get 6 to 10 in the morning, your charges are higher. 2 to 6 in the evening, your charges are lower, but then at a risk.
No, but then you will not be justified in doing
It's a
this
question of
kind of
justification because
No.
it's not a modern medicine concept. Modern medicine doesn't talk about it.
Yes, it doesn't.
But then you can't.
yes.
But you can't stop. But you can't stop 2 to 6.
No, but you have to justify why you're treating a certain patient at a certain time.
The prime time. That's all. Availability of doctors. Prime time. You don't have to give
We are
explanation
24
for
into
that.
7, so everybody is working.
I'm only trying to say, even if it is not,
Mhm.
do it. It may be a wonder. It may come out to be a unique thing.
Yes, we have an Ayurvedic unit with us. We can work with them.
Not required, no.
Not required, but
Because you are only doing the timings. They are not going to judge whether it is a, we are not talking about a Vata person getting a Vata time. We are not talking about that's a different concept altogether, that which people should get.
the kapha radiation and who would get the Vata radiation.
Yes,
So
but that means a Kapha person will get a, say for example, if a person is a Kapha personality, should he get in Vata time or a Pitta time or a Kapha time? That's altogether.
that's
There
it.
you need the association. I'm only talking about it that divide your days into 4 hours each and see which people gets the minimum.
Yeah, thank you for the suggestion. I think we can look at it.
Yes, I'm talking about it. Now, and when we talk about safety, we talk about quality. Many things in quality and safety.
In quality and safety, we also have a regulatory authority. It is the Atomic Energy Regulatory Board, which is situated in Bombay, and it comes under the Department of Atomic Energy by the government promulgation. And they have a certain set of guidelines which have to be followed for any radiation generator or any equipment that's brought into our country, and they have to come and certify after its installation and commissioning, and a license has to be given by them for operating any radiotherapy equipment.
Now, how does radiotherapy differ from X-ray? Both are ionizing.
Both are ionizing. It's a very good question. An X-ray, or as we understand an X-ray, is a machine which generates only about 200 kilovolts of radiation.
Mm.
And a radiation therapy unit or a linear accelerator produces mega voltage radiation, which is to the tune of 4 million volts, 6 million volts, 10 million volts, and up to 21 million volts. So it's very, very high energy, MV, megavolts. That's what is produced. And that energy is more penetrating than the X-rays. So X-rays, when they are attenuated, give you a gray image. So depending upon the atomic number of the bone being very dense, it gives you the image of the bone. And you can see the lungs which have air and which are black in color, and thereof you have different grades which you can pick up. So is true of the CT scan, and so where you're using the X-rays for attenuation, and it's a computerized axial image which is displayed as a grayscale image. Here the radiation is made to get absorbed at a certain depth within the body, and it's absorbed there, which is what denatures the DNA of the tumor. So the radiation is the same, it's the electromagnetic radiation, but the energy is much higher.
Energy is much higher.
Much higher. And also we have protons where we go up to almost 250 million volts. So that's much, much higher.
Now, there's always a confusion between ionizing versus non-ionizing. So we have non-ionizing, we have ultrasound, we have CT, we have MRI, we have mobile phones, mobile towers. There is the interaction.
Well, the non-ionizing radiations, let's understand what is ionization. When we give an ionizing radiation or a radiotherapy treatment, when we introduce the beam of radiation into the tissues, it ionizes the molecules. So mainly the body 70% is made up of water, and water molecule is formed of 2 hydrogen atoms and 1 oxygen atom. So that is denatured. So there will be 2 hydrogen atoms produced and 1 oxygen atom, and this oxygen atom is the nascent oxygen, which is a free radical, and it's ionized. So this is what goes and denatures the DNA. The double strand break occurs there. So this is the basic mechanism of an ionizing radiation. The non-ionizing radiations are ultrasound and MRI, and they are not going to denature the molecules or cause a damage to the DNA. So this is the basic difference.
And why do you say the people who are going chemotherapy, radiotherapy should not go for ultrasound?
The patients who are undergoing radiotherapy can have an ultrasound as a diagnostic modality. But in case they need a physiotherapy or they have a bruise, then we advise them not to have an ultrasonic massage. or have an infrared massage or infrared treatments, because that increases the blood supply to that area. And whenever we have the tumors, they produce angiogenic factors which increases the blood supply and brings the nutrition to them. So that principle then will increase the number of tumor there.
So it is something like,
which is
because in an ultrasound, you use ultrasound.
Ultrasonic massage.
You see, that's the principle. You use an ultrasonic massage with the painkiller tube, so that the drug absorption gets increased. So sometimes to make a drug absorb better, you use an ultrasound massage.
So in patients who are undergoing radiation treatment, we advise them to take TENS or do only massage or pressure. So gentle massage is what is required. We do not allow them to even use hot water bottles.
What about mobile phone, mobile towers, no restriction?
No, mobile towers and mobile phones, there's been a lot of controversy in the recent years about these. They are non-cancer producing, and
patients on chemotherapy.
On radiation, they can use sparingly, especially for patients who are because the microwave radiation, which is there on the RF radio frequency, which is available on the mobile phone, that heats the body of the mobile phone, right? So if it's held close to the area, so then the principle of heating again comes in, what we were talking about earlier. So then they shouldn't be using the phone close to their ear. They can use.
But one thing is, because there is always a controversy that mobile phones are linked with acoustic neuroma or with brain tumors. Patients with brain tumors should not use it.
They should not use them, or they can use the earphones. And then
all the precautions they need to take.
And hands-free is the
hands-free is without it. Last thing we come back to is accountability.
Yes.
What can go wrong, and what are the mistakes can happen? And when I say mistakes, I'm not talking about criminal negligence. To error is human. I'm likely to make errors, and for my error, I'm getting my insurance done. So, in which are the situations where if error happens, my accountability is also.
Radiation therapy and its delivery has become very complex over the last few years, and most of it has become digital. So the error can happen not only from the human contact, but also from the digital failure. So if a patient is on the table and radiation beam is not switched on, and it's believed that the patient has received the radiation, so there can be a miss. So that is one error that can happen. Or a patient is called out, and in India we have common names. So if you do not have a unique identifier, or you have a way of identifying the patient, so then an error can happen. But those we are taking care of by having two unique identifiers. One is the name of the patient, and we give them a band. Secondly, we have their unique ID number. And third, we have a picture also taken before the patient comes for the treatment. So that is shown to the technician, and a picture is shown. And all these three things are related, so that that error of misidentification is not there. One is this digital, second is this. And the third is that, at times, the equipment that's being in use for longer time, that may not perform optimally. So the beam of radiation which we are thinking is going to deliver 200 units may actually be delivering 180 units. So what we have to do is to periodically monitor the quality of the beam, so that the same number of units are being delivered every day. So we have an extensive...
And what about radiation injuries?
So radiation injuries can be in case of excessive irradiation that has been delivered, or an overexposure which is unintentional. That can happen either in the industrial setting or in the hospital setting also. Like I don't know if you're aware about the New York accident that happened, the incident in one of the hospitals where a patient was given multi-leaf collimator treatment, where the beam was to be intensity modulated and a small aperture of the radiation beam needed to be opened. But the collimators, they moved completely into the open position. So the patient got a large field radiation, and the dose was much higher, almost 10 times higher than what was supposed to have been delivered. And the patient ultimately succumbed to the radiation injury. So those are the kind of accidents that have been recorded, and they are shared. So we have an accountability, and we have a grid whereby we go back and do repeat checks, and self audit is done, so that these kind of accidents don't happen.
Now let's go unconventional, something about your department. Radiation department at Medanta. Yes. So is it, Medanta has now so many units, is it only at Gurgaon?
Medanta, the Medicity at Gurgaon, has the largest radiation therapy department. We have 6 bunkers, and and we are equipped with linear accelerators, a cyberknife, and tomotherapy. And outside of America, only in America, John Hopkins has this kind of a configuration of treatment units, which we have at Medanta in Gurgaon. And Medanta now is opening up at Patna, Lucknow, Noida, and Ranchi, Indore. So in Patna and Lucknow, we are planning to have a radiation oncology department, but at other centers, we are going with other super specialties.
So I would take that now Medanta will have in Gurgaon, in Patna, and
Lucknow, we'll have radiation oncology.
Radiation oncology. Same unit, same type setup?
In Patna, we are planning to have 2 accelerators. In Lucknow, we are planning to have 4 bunkers. And in Noida, that's also being discussed, we'll have, and we'll probably have 2 units there.
Something about you.
My name?
Why did you enter into radiation oncology?
Well, I did my graduation from Simla Medical College, and I was
Shimla?
Yeah, Simla Medical College, and I was keen to pursue radiological branch. So I applied for radiology and radiotherapy both, and got into radiotherapy, and here I am. I was also interested in physics and maths from the beginning, so it fulfilled that part because I do a lot of physics in the planning and.
Why Medanta? Why didn't you go to the hospital, government hospital, medical college, and produce more people?
Sir, I came to Delhi in 1990 after passing out from PGI and doing my senior residency as an assistant professor at Maulana Azad Medical College. And I was there for 4 years. I was promoted within 1.5 years to an associate level. And we had a continuous dialogue with the government, the then government, and the ministry to reorganize that department. I've given them the drawings at that time. Nothing has happened. And it's been 24 years when I left that unit to join Rajiv Gandhi. So I set up the department there, moved to Artemis, and I'm at Medanta. So I did try my very best to give back to the society, public hospital.
This is the last destination?
I think so. I'm 56 now.
44 years to live.
God willing, I don't know, but I think this is the center which I would like to evolve to a world-class level and then give it up from there.
Okay, we still have around 10 minutes. How much is the time now? 10 minutes. We still have 10 minutes, so let's come back to some specific cancers. Okay, so number 1 cancer in the country is cervix and breast.
That's amongst the women.
And that is head and neck
And lung
and
cancer.
lungs. So a person comes to you with cervical cancer, suppose. Can they come to you directly, or they have to go to a physician, and you, at what stage they will refer to you? Can you see the patients primarily?
I can see the patients primarily.
Because why I'm saying is because the classical example is Dr. P.K. Julka, who is a radiation oncologist, but in the society he is like a panacea oncologist.
So we see the cancer patients ourselves. So a patient can walk into my
So therefore,
clinic.
Primarily a patient can walk into each one of them,
Each
to
one.
a surgeon or to an oncologist or to a radiation oncologist.
Yes.
So for a patient of cervical cancer comes to you,
Yes.
what will you do?
So first is their history taking, and then the clinical
Diagnosis.
examination,
Then the
and
biopsy.
diagnosis and biopsy. Then we do the staging of the patient. That's very important, whether it is loco-regional or local, or there is a distant metastasis. After proper staging up to stage 3B, radiation is the mainstay of treatment for cancer patients of cancer cervix. Unless the patient is a woman of childbearing age and they are early stage, then we would prefer them to go for surgery up to stage 2.
So therefore, if a patient comes to you with a cervical cancer, he will get all the advice. If surgery is needed, you will have a tie-up.
Yes, we have the
Get the surgery done.
Yes.
And if chemo is required,
Then
either you will give or you get it done by the medical oncologist.
Although I'm trained to give chemotherapy for the last 20 years, I'm not giving chemotherapy. So I have a very good medical oncology unit with me. So we
So
work in tandem.
therefore, if they come to you, you decide, and you doesn't have to wander here and there. You take all the decisions.
Yes.
You say you get it done or get the surgery done, come back to me.
Yes.
What about breast?
For breast also similarly, we can have the patients directly seen by us. and have their diagnosis made. We have a good radiology unit with ultrasound, mammogram, MRI.
Where is the role of radiation? Yeah.
And the radiation is now, if we look at the breast cancer cure, then 30% of the contribution is coming from surgery, 30% from radiation, 30% for ER/PR positive or receptor positive patients from their tamoxifen and aromatase inhibitors, and 5 to 10% from chemotherapy. So radiation has almost 1/3 contribution for curing breast
So
cancer.
probably every patient would need radiation.
Almost
practically.
80% of patients.
80% of them. So therefore, they can come to you. You can plan.
Yes.
Whenever they need radiotherapy, you give them.
And
And what
before
about
and
you?
after, they can be taken for
And
surgery.
breast conservation surgery.
Breast conservation surgery is being done at Medanta. We have 2 trained surgeons who are working with us,
And they are the role of
and
radiation.
chemotherapy is depending upon their need, if the lymph nodes are positive or their adverse.
What about head and neck? You said radiotherapy is primary.
Primarily because face and the head and neck are the aesthetics and of a personality and a person, and we work very closely with our head and neck surgeons for oral cancers. Surgery followed by radiation gives us the best results, and we also have a plastic surgeon on board who can help that. For nasopharynx, larynx, hypopharynx, radiation and concurrent chemo if required.
What about lungs?
For lung cancer, we have a cardiothoracic surgeon. He's doing mainly the thoracic surgeries. So we work with them. The patient can walk into us, into our unit. We have a pulmonary medicine department.
Okay,
where
let me
we
come
do
back. Let me come
biopsies.
back. With today's scenario, where you have all the 3 departments, I will add another 4th one is preventive oncology. So suppose preventive oncology is also there. A patient with cervical cancer today, if what is the lifespan possible if diagnosed early?
For a patient with stage 1, 1A1 or 1B, the cure rates are more than 90-95%. For stage 1A, 98% is the world record from MD Anderson. And we have our own patients who are now surviving for almost 20 years. And for stage 2, 80-85% patients. We say 5-year survival, that doesn't mean they are not going to live after 5 years. After that, their lifetime cohorts, they join the normal lifespan. So if they were to live from the age of 60 to 80, they will go on to live that space.
Cancer-free 5 years.
So cancer-free 5 years is what we
call
calculate.
them as.
And for stage 1 and 2, more than 80-85% of cancer
Breast.
patients. For breast, again, stage 1 patients, 97% of them with breast conservation are living at 20 years.
Head and neck.
For head and neck, the control rates are slightly inferior. In stage 1, we get 80% cure, and in stage 3, up to 50% of them can be cured.
Lungs.
Lung is not a very good disease, especially
So that's what our main number 1
advanced.
is.
That is our number 1, and the diagnosis is not made easily. For stage 1, the ones who get operated who are candidates for stereotactic body radiotherapy, 75% are cured. And in stage 3, especially if they are adenocarcinomas, and we were talking of targeted therapies and antibodies earlier on, in case they have an ALK mutation, and Southeast Asian population, including India, adenocarcinomas of the lung have an ALK mutation, here we have 40% survival at 5 years now. In stage 3
So when we were told lung cancer in 6 months.
No. I have almost patients who are now 5 years and now they're living. They're doing well. And even for patients with lung cancer, with adenocarcinoma, or patients with squamous cell carcinoma who have an EGFR mutation with brain metastasis, they are
So what
living
about
beyond 2
prostate?
years now.
Because another cancers which are coming are prostate.
For prostate cancer, if the patient has up to stage 2 disease, or B, what we call them, and they are low to intermediate risk, more than 80% of them are surviving. And the patients who are in stage 3.
What about surgery versus stereotactic radiation in the prostate inside, putting the pellet inside the.
The results are equivalent. So there is no controversy now. A lot of debate has occurred in the last 10 years, and now it's settled down that surgery or radiation for early stage has equivalent results in carcinoma prostate.
Well, then radiation has to be better because.
It has to be better because there is no incontinence,
sexual life,
there is no erectile dysfunction.
and then, I mean, you are.
So day before yesterday, I was talking to a patient's son who is a doctor in States. He says in USA, 80% of prostate cancers are going for radiation now. So there's been a sea change.
What about radiation-induced secondary cancers?
A very good question. Radiation causes the genetic damage or the DNA damage for the tumor. And there is also, we talked of the abscopal effect. So if you are getting radiation for the skull or for the brain tumor, some part of the rest of the body will also be getting that radiation. And ionizing radiation is a category 1 for production of cancer. So it leads to mutagen or mutations which can produce cancer. And this was recorded from the children who were treated and cured for Hodgkin's lymphoma in their childhood, and also survivors of Hiroshima and Nagasaki. So our intent always is to minimize the dose of radiation. So there are protocols where the dose of radiation has been reduced to half, and radiation and chemo has been added on. So chemo and radiation
Specifically leukemias.
Specifically leukemias and lymphomas in both.
No, look, you're doing cancer breast therapy,
Yes.
radiotherapy for breast cancer, patient ending up into leukemia.
That is because of the effect of the radiation, but
Hmm.
that is something the patient would not be living in case you had not treated them with radiation. So that's something, a trade-off, it's kind of a professional risk.
So is it something like that, let people follow it or not, that all patients who have lost radiotherapy in future, no X-ray unless it is a must, no CT scan unless it is a must, avoid excessive use of mobile, microphone, microwaves, everything.
So
I mean, I'm theoretically.
No, we talk to our patients, and we prefer to do an MRI and ultrasound on follow-up of our patients rather than do the PET scans and CT scans, and also avoid the X-rays in these patients. And regarding the mobile phones, there's still controversy for acoustic neuromas. So we tell them that you use hand-free. So we do, counsel our patients on their follow-up.
IMA is working on a policy. At Indian Medical Association, we are working on a policy about radiation history.
Mm-hmm.
So we are saying every patient should have in his file write down radiation history, cumulative effect. I'm not talking about only radiotherapy, but even image, whatever. How many images, how many CT scans have been done in his life, how many X-rays have been done. In a CT scan, you should go and ask him how many slices have been taken off, how much time it has. So is it, we want to calculate millisieverts of radiation history. Sooner or later, this is going to come.
This is already available on the present generation CT scanners
But
and the X-ray units.
They don't write down.
So, like in England, it's mandatory that a patient carries the chip and the medical history with them as to how many exposures have been done, why an X-ray was done, why a CT scan was done, what is the need for doing a next CT scan or a PET scan for a patient. So I think in India also we have to start looking at that.
Sooner or later, somebody will have to
because
start.
it's not a risk which we should be giving to our next generation of people who are coming in. So it's something which is very laudable that if IMA is taking it up. But they are available on the CT scanners. The equipment manufacturer has to specify how many sieverts or millisieverts will be delivered with each exposure.
So it's now a couple of minutes left. 5 points if you have to summarize. For public and for the GPs and for the doctors.
The message that I want to convey to the public and to the GPs is that radiation is one of the strong pillars of treatment for cancer patients. In our country, the latest equipments and the best techniques are available pan-India, and
So you don't have to think of zone catering, you have everything available.
yes, we have everything available in our country, and we also have skilled doctors, physicists and technologists who are able to deliver quality assured treatment to our patients, and along with the surgical and medical oncologists, the patients of cancer can be offered a curative treatment. We should not give up on that. And another message which I want to convey to every one of you is that cancer is not something we should be afraid of. It is curable if it is detected early. We have to be aware of
everybody
its
apart
symptoms.
from your regular insurance also think of a cancer insurance, because there are some schemes available which only covers cancer.
I think that's very good if they can do that.
And people should be aware of a reverse mortgage. I hope you know what reverse mortgage is.
For the equipments in case
No.
or for their
There is a concept
insurance.
called reverse mortgage.
Okay.
Reverse mortgage is, suppose I am 70, 80-year-old.
Mm-hmm.
I own the house
Mm-hmm.
and my children are not ready to take care of me.
Okay.
Okay? So house is mine, they are waiting for me to die so that they can take care of the house. So I can go to the bank, give my property to the bank. My bank will give me, say, ₹1 lakh a month for my treatment.
Okay.
No questions asked, no money to be returned, no interest to be paid.
I think I wasn't aware of
At
that.
the time of my death,
Mm.
the bank will go to my children and say, hey, 2 crore have been spent, give me 2 crore, take the house, otherwise I'm selling the house and giving you the 8 crores. So all those people who says that I have no source of income, I only have a house. What do I do? The house is not sellable, nobody wants to buy it, so they can reverse mortgages to the bank
For their health.
for their health money. The bank will take care of, give you the loan, and bank will recover at the time of your death. So you don't have to bother about, even if you live for 10 years,
Your health will be taken care
your
of.
health will be taken care of out of the money which you have earned for yourself.
That's
And
right.
your children may not be even aware of that. This is what you have done.
I think
You
it's
don't have to
very
tell your children that you are doing that.
Okay.
So this is pertaining to cancer patients because they know
Children do not want to spend the money.
A, they don't want to
Savings on
spend
their
the money.
parents.
B, it's costly.
Yes.
B is costly. And C, the lifespan is whatever you do, you're not talking about 5 years, 10 years, you're not talking about 40, 50 years in every case. So
Yes, in
therefore,
early cancers you are.
no, because you already said more than 60% comes in
Can-
stage 2, stage 3.
So that's what the message to the GPs is, that
Yes.
they need to start
That
identifying
is one.
cancers early.
But those people who are coming late,
Yes, there has to be a way of treatment to them.
the answer should not be because he is stage 3, stage 4, let him die.
No, I think.
But that's what will happen now. Because when you tell the children that you're going to spend 50 lakhs and you're not sure about the thing, they say, leave it to the nature. So if the person himself has to take a decision, reverse mortgage is available,
Okay,
he would go for everything.
thank you. I think that's a very good concept.
My last question, that if someone close to you develop a terminal cancer means you know that with or without treatment, 1 or 2 months extra, what would you do?
So I think then in that case, we have to talk about the quality of life. It's not the quantity of life, it's the quality of life. So whatever needs to be done to keep the quality of life, maintain the dignity of that person, make them compost mentors, keep them pain-free, should be offered. And a transparent discussion has to take place with the caregivers, with the patient, him or herself, so that they are able to make those decisions. And once we do that, then the life is easier for everyone involved.
My last line, how is your boss? How is he as a...
I think I've met a very good mentor in Dr. Trehan, and we had a very long discussion when we were starting off, before I joined the organization, as to what is required for radiation oncology. So the discussion happened that what is required for a cancer patient from radiation oncology, and based upon those lines, we've been able to set up
Total
this
freedom and total
option.
autonomy.
Thank you so much.
That's all for today. Let's thank Dr. Tejendra Kataria to be with us. And this video will be available, which you have seen it in eMedinexus.com as well as on IMA website, IGCP website, and Heartcare Foundation website. This will be available on respective sites for the next 1 year. We'll come back with one more show next Thursday, and next Thursday we will have another one from Medanta itself, Dr. Neelam Mohan, who has recently been conferred Dr. B.C. Roy Award. We'll be talking about a lot about liver diseases in children. Let's thank Dr. Tejendra to be with us, and I say goodbye to all of you. We'll see you next Thursday, same time. Thank you.